Hi, it's Dr. Kathy Miller from Indiana University, here with you today to talk about what I think was one of the most important trials reported at the December San Antonio Breast Cancer Symposium meeting. Now, I'm talking about the PATINA trial. This is a trial that was not on our radar as we were looking forward to the meeting. In fact, it wasn't on the agenda because the results didn't become available until about a week and a half before the meeting kicked off. So kudos to the authors for getting this data out there and to the organizers for recognizing the importance and finding a way to add this to the program. Now, the PATINA trial enrolled patients whose tumors were both HER2 positive and ER positive. That is about half of our patients with HER2 positive disease. And you all will know that almost all of our trials looking at HER2 targeted therapies did not allow patients to continue anti-estrogen therapy. Now, patients could have had anti-estrogen therapy before they came to those HER2-focused trials. Some did, some may not have. It was not a requirement, but they could not continue it. Now, the same is true for patients with ER-positive disease. If your disease was ER positive and HER2 positive, you were excluded from all of our recent trials focusing on ER positive disease. That includes those looking at the benefit of cyclin-dependent kinase inhibitors. It also includes those looking at PI3 kinase inhibitors, AKT inhibitors, selective estrogen receptor downregulators in their oral formulations. We've had to pick. Do we want to focus on HER2 or do we want to focus on ER? And the PATINA trial results are not only important for practice, they show us the problem in that dichotomy. So PATINA enrolled patients who were receiving their first chemotherapy and HER2-targeted therapy for metastatic disease. Once they had received at least 4 cycles of combined therapy, they could receive additional chemotherapy, but they could also move into a maintenance phase if their disease was responding or stable, continuing HER2-targeted therapy alone without chemotherapy. At that point, hormone therapy was reintroduced. This is a common practice for many of us, and those patients were then randomized to either palbociclib or not. Now, this was a large effort, 518 patients in this randomized trial. The expectations of progression-free survival were based on the results of the Cleopatra trial. So the trial assumed about a 15-month progression-free survival in those randomized to the control arm. What was actually observed was a 29-month progression-free survival. Now, 2 things might have contributed to this difference. First is that the Cleopatra trial did not allow patients to receive concurrent hormone therapy, and that may have had a major impact on its own. Also, Cleopatra reported the PFS for all of the patients enrolled. To get into PATINA, you had to be responding or stable to your initial combined modality therapy. So those patients with really resistant disease who progressed early were excluded, and that may have had an impact as well. Now, with the addition of palbociclib, that 29-month progression-free survival became 44 months. So stop and think about this. Almost a 4-year period of time where patients were on trastuzumab and pertuzumab, an AI, and a cyclin-dependent kinase inhibitor. No chemotherapy, much less day-to-day toxicities. Not no toxicity, but less of the day-to-day toxicities that patients are really troubled by. Now, we don't yet have mature overall survival data. That will be coming. You can imagine with progression-free survival nearing 4 years, overall survival data will be some months or years hence until there are enough events for us to look at that evaluation. I think these results should immediately, realizing there are going to be issues with insurance approval and regulatory approvals, but I would like to take these results into account for my patients in that situation. It also challenges those of us who are developing clinical trials, who are developing drugs, to realize studying targets in isolation might be needed, is needed early in the development of new agents. But to get the maximum benefit for our patients, you need to put those building blocks back together and stop this forced dichotomy. That doesn't serve our patients well, and it's not where we will need to be in the future.